Now, the next is Padalaha and Padaharsha, the two of the Nanavyadhis, Vatavyadhis. पादयोः पुरुके दाहं पित्तासहितो अनिलः विशेषतः चन्द्रमणात् पाददाहं तमादिशेत् हृष्यतश्चरणो यस्य भवतश्च प्रसुप्तवत् पादहर्षः सविज्ञेयः कफवातप्रकोपजः. Now, Padadaha and Padaharsha are those conditions where there could be either burning sensation or there could be numbness or altered sensation, even there could be exaggerated sensation. Now, these are really the clinical presentations which do occur in case of the ischemic pathology. Now, Vata Rakta also is suggestive of the ischemic pathology. Raktavrata Vata also is suggestive of the ischemic pathology. And Pittasuk Sahitaha Aldaha, Pittasuk Sahita Anilaha, where Pitta and Asuk are involved, and then the Rakta is involved, Vata is involved, that also produces the Padadaha. Now, to make out that, you need to look at the clinical description of the ischemic conditions. Now, ischemic conditions are graded. Usually, standard gradation would be into either 0 to 4 or 0 to 6 categories. Now, if you look at that, the clinical symptoms which do occur are initially it could be asymptomatic. Then in the next stage, there could be a mild claudication, and during that stage, the patient would have a typically inflammatory changes in the muscles over the area, and due to that, there could be burning sensation as such. Initially, that's the typical clinical symptoms which occur in the initial stage. As the condition progresses, the next would be the sensory nerve endings. They become hyperactive. So hyperesthesia or maybe the numbness could be the clinical symptoms as such. And then, of course, once it progresses further, it results in the claudication and the severe claudication rather, and then could be the rest pain and so on, which we have already discussed during the case of ischemic pathology. Now, probably Padadaha, Padaharsha are that initial conditions where the patient would have the initial symptoms as such. Now, the other way to look at it is if you look at the other way grading, the PF grading or FP grading. FP grading is also another method of grading the ischemic conditions, particularly peripheral vascular results. The TA, the thromboembolic obliterans, is graded, and that grade 1 is in those conditions where the vessels are involved, the area or length of the vessel involved is less than 10 centimeter. In that condition, there would be a relatively minimal symptoms, and the only symptom the patient would have would be the burning sensation. Now that's exactly the point which is mentioned, like, and grade 2 is when the distance covered or the length of the artery having this ischemic changes or blockade NDITs is 10 to 20 centimeters, and in that condition the patient would have the clinical symptoms where neurological deficits would occur and mild claudication would occur. The symptom, and there is always a tendency for the adaptation changes in the muscles. Now, adaptation changes we have already discussed in the previous session when we discussed about Vatrakta. Now, then of course, you have grade 3 and grade 4 where the length involved would be more than 20 centimeters, where you will have the frank ischemic signs. Now, the what you have to understand is what the present outlook about the ischemic diseases. We look at these clinical symptoms as the stages of the same disease, whereas Sushruta had identified these as separate disease entities and named them as a separate diseases. But in fact, if you really see the patients now, you will have many of the patients who remain in that grade 1 or grade 2 for quite a long time and may not reach to the grade 3 or grade 4. But we are now accustomed to the outlook where any patient who is seen in the early grade, you would always expect or maybe predict the risk of the patient going into the next stage, and we go for a preventive approach. But there are many patients who remain in that stage of grade 1 and grade 2, and we do not have any means by which we can predict like whether the patient would remain in the same early stage or whether the patient would go into the next stage. And hence, we are now having a mindset where We always consider these as the stages of the same disease. But if at all you have a definite clinical clue by which you can predict like which of the patients would go to the next stage, which of the patients would not go to the next stage, then it's absolutely justified if you can name them as the different entities. The name like whatever the name you give, Padaharsha or whatever that Vata Rakta or so Rakta or the Vata or Vata Rakta as such. And so there is no question of confusion. Sushruta might have had that kind of a clinical clue which we have lost, by which he could predict like which of the patients would go to the next stage, which of the patients would remain in the same stage, and this would also have some difference in the clinical approach, treatment, the therapeutic approach too. See, in case of Padula and Padaharsha, the priority would be to treat the Vata, whereas in Vata Rakta, the priority would be to treat the Rakta Drishti as such. So that's the differences. Now, anyway, that's about one of the issues. Now, next of the condition is Avabahuka. Avabahuka is a अंशदेशस्थितो वायुः शोषयित्वा अंशबन्धनं शिराश्च आकुञ्चितत्रस्तः जनयति अवबाहुकम्. Now, Vishwachi and Avabahuka, they are Vishwachi, which we have discussed in the previous session, where the patient would have pain as a major clinical symptom. Along with the pain, there could also be the loss of functions of the muscles and the amsa, the shoulder blade or the scapula could be raised up, hinging of the scapula could be possible. Whereas if there is a shoshana or a definite atrophy of the Amsabandhana is all that the scapular muscles, scalenus muscles, and subscapular, suprascapular muscles, even to a certain extent biceps. Now, when these muscles they tend to become atrophied, and hence the bulging of the shoulder would be reduced. What you see would be typically in a normal shoulder you have a bulging, but in case of these conditions, there will be no bulging or bulging is reduced, and the patient would also have the signs of ischemia, peripheral ischemic signs. Then really the pain, neurological symptom. Of course, pain would be there. That the pain produced in case of ischemic pathology, pain produced due to the nerve compression. Pain produced due to the nerve compression would be a typical radiating pain which starts from the origin area to the tip. Whereas in case of ischemic pathology, the pain would have typical claudication-like symptoms. The patient would have pain when the patient does exercise more, or there even can be atrophy of the muscles which are involved, and very prominently the atrophy of the shoulder muscles. Now, this can be very commonly seen in case of mainly what we call as anterior scalene syndrome. Anterior scalene syndrome, one of the most common cause could be cervical rib. And for the cervical rib, the clinical test is Adson's test. In the Adson's test, what you do is feel the peripheral pulse, the radial pulse, keeping the neck in the neutral position, and then turn the neck towards the same side, and these extend or outwardly rotate the shoulder so that whether this pulsation is reduced or pulsation becomes absent. Or then the other way would be a right test where the arm is raised up and then externally rotated, or it could be also the fast test where abduction of the arm also reduces the strength of the muscles or produces the pain in the patient. These are the typical tests which are done to confirm whether the blood flow to the periphery is normal or not, or whether the brachial artery is compressed or not. So, a arterial compression and resulting in ischemic pathology is a typical presentation of avabahuka, whereas a neurological compression which produces radiating pain and atrophy of the muscles, that's in case of the Vishwaji. Now, this is in case of thoracic outlet syndrome, which we now categorize as one specific entity. There will be both arterial as well as the neurological compression. In case of cervical rib-like conditions or anterior scalene syndrome, it is mainly the arterial vascular pathology. But for the practical purposes, we consider all of them together, and then we use the term frozen shoulder syndromes the other way. Now, these names are misleading. Frozen shoulder syndrome is again syndrome where you are not able to make out whether it is a arterial pathology or whether it is a neurological pathology, or there could be a mixed of conditions, and hence in such conditions we use the word frozen shoulder. And when you know exactly like whether it's a vascular pathology or the neurological pathology, we use the words specific like either cervical rib or skeleton syndromes and so on. Thoracic outlet syndromes, which usually occur. Thoracic outlet syndrome occur due to some compression or narrowing of the thoracic outlet. And most important in case of that thoracic outlet syndrome, the most important cause is the neoplastic conditions of the pleura. The external pleural neoplastic conditions or lung tumors, tumors of the lungs also can produce the thoracic outlet syndrome. So in a patient presenting with these clinical symptoms, it's quite important to confirm that. And thoracic outlet syndrome can be better confirmed by the raise test. Raise the limb up. Actions test, keep the arm low, it's for the, and turn the neck towards the opposite side. Whereas in case of raise test, you raise the limb up. This confirms the thoracic outlet syndrome, whereas the actions test confirms the cervical rib conditions. And in case of the abduction with abduction and exercise, producing the pain is very common in case of the mixed lesions. Many of the diabetic patients presenting with the ischemia or frozen shoulder syndrome would have this kind of a situation where the abduction and exercise would aggravate the pain, or at times it could be costoclavicular compression also can produce the pain in case of that frozen shoulder syndrome. This is how we clinically make out those patients presenting with the pain in the shoulder. So patients presenting with the pain in the shoulder and inability to move the shoulder up or presenting with the neurological or the other way pathologies, this differentiation is quite important. And quite important the other way is Sushruta had made out these differences, neurological differences, arterial differences, and clinical presentation of that was well studied, and that's how we have to appreciate Sushruta's clinical perception. Now, the next is Bajilya or deafness. यदा शब्दवहं स्रोतः वायुः आवृत्य तिष्ठति शुद्धः श्लेष्मान्वितो वापि बाधिर्यं तेन जायते. Now, Badhirya or deafness can occur due to mainly two types of the pathologies. One is the bone conduction or the nerve conduction. Bone conduction where the waves of the sound they fail to reach to the bone, and the or rather conduction of the waves in the through the bones is affected and the nerves do not get stimulated. So it's in the ear, internal ear, or somewhere in the periphery, external auditory meters, and so on. The other way could be there could be some pathology somewhere in the neurological pathway, and neurological pathway is starting from the auditory nerves, and then throughout the pathway where they a few of the fibers do decussate and few of the fibers do not decussate till the auditory area. Now these could be what we call as the nerve conduction defects, defects of the nerve conduction, and you have elaborate clinical protocol of making out that. So when a patient comes to you with an impaired hearing, the first approach would be you'll have to decide whether it is a nerve conduction defect or bone conduction defect, and then the whole approach to the planning. Now, Susan has made out exactly the same thing. Either it could be Shabdavaham Srotah Vayu Avritya Distari. Shabdavaha Srotas, these neurological channels, they could be blocked, or Shreshmanvitaha, there could be Shleshma, some discharges or sort of some component in the periphery. Shleshmanvita bacteria is the bone conduction defect, and the Kebala Vatajanya is the Shabdavasruto Avartya study or Vatavaranajanya deafness. And from the clinical treatment point of view also, these would have a difference. That part we will discuss when we discuss the Chikitsa as such. That's about one more of the vatavyadhi. Next is the Karna Shula. Hanusankhashiroprivam yase bhindan nimanelaha karnayoh kurute shulam karna shulam taduchere. Patient presenting with a pain or atalgia, conditions of pain. From the clinical point of view, conditions which produce the pain in the ear, patients presenting in the pain in the ear, there are huge conditions, large number of conditions can present with. It could be starting from the primary pathology of the ears, or it could be that of the inflammatory changes or changes in the skin and the surface of the ear, external ear, pinna of the ear, or it could be abnormality of the nasopharynx, or maybe the sinus around the facial area, where again the patient may feel the pain in the ears, or it could be like intracranial lesions. Tumors in the brain also can present with the pain in the ears. Patients with the lesions in the temporal fossa, particularly oral cancer, it also can present with the pain in the ear. Dental pathologies can present with the pain in the ear. Oral cavity, tonsillar lesions, often, very often, when it comes to the question, very often they may produce the pain in the ear, or the musculoskeletal pain in the neck also can present with pain in the ears. Patients having lesions of the thyroid or larynx also can present with the pain in the ears. Patients of trigeminal neuralgia also can present with the pain in the ear. So when a patient presents with the pain in the ear, it's quite important to know exactly like which is the cause. And elaborate exercise of investigations may be needed. But when it comes to question of majority of the patients, the most common causes of the pain in the ear would be patients having the inflammation in the either external auditory meatus or eustachian canal obstruction. The most common is the eustachian tube getting obstructed due to cold or so on. Persons who have taken ice cream or cold things, and then there is a inflammation of the pharynx, and then the eustachian tube get blocked. And blockade of the eustachian tube is one of the most common conditions where the pain would be quite severe, acute. And probably when Srishra has mentioned about the Karnashula, it could be about this condition than the other way. When it goes to the Chikitsa, when you read the Chikitsa, you know about that. Srishra probably has considered Karnashula as the pain produced due to blockade of the Eustachian canal, and hence there is a increased pressure in the middle ear, and once the pressure in the middle ear has increased, or there is a gradient of pressure difference between the middle ear and the external ear, you will have quite severe pain, and probably this is the condition, though Sushra has not given out all the details about the other possibilities. But from the practical clinical point of view, it's quite important that you know how to assess all the other possibilities before you conclude whether the patient has a real significant pathology or not. So the important is there could be quite huge conditions which could have very severe prognosis, extremely poor prognosis like tumors, or it could be like conditions which may have a better prognosis. Simplest and the most common and easy to treat are the eustachian tube blockade, which is often produced due to the pharyngitis acid. That's about the causes. Then the next of the conditions is a Muka Minmina Gadgada. The patients presenting with a abnormal form of voice presentation or voice formation. आवृत्य सकपः वायुः धमनीः शब्दवाहिनीः नरान् करोति अक्रियकारण, where there is a abnormality of the functions. It's a dysarthria, and they are categorized as Muka Minmina Gadgada. The exact textual meaning of the word muka minmina gargar is muka is where the person cannot speak at all, or is not able to produce the syllables, and minmina is where the sound quality is affected. Gargada is where there is an interrupted speech, staccato speech, like he cannot speak continuously, everywhere there is a blockade. So there are three components. Either there is a no sound formation at all, voice formation is absent, or the quality of the voice is having a nasal intonation. Mimina is a nasal intonation. Gargala is where there is a interrupted speech, or there is no continuity of the speech as such. And the reasons could be आवृत्य सकफ वायु धमनी शब्दवाहिनी, शब्दवाहिनी धमनीs, all the nerves which are related to the formation of the speech. We have referred to this, the nerves which are important for the formation of the speech is when we discussed about the udana vata. Now it could be any of those nerves which are affected, can result in the dysarthria, different types of the dysarthria. In the present day situation, we generally make out the dysarthria types into 7 types. Sushruta has mentioned three: Muka, Minmina, Gadgada. Now we have 7 types of the dysarthria. Among them, ataxic, which is usually a irregular articulation, it's a variety of Gadgada, where the patient would have breakdowns and the patient is usually due to cerebellar lesions, as you see in case of Parkinsonism like patients of Parkinsonism, you will see the same feature. That's the Gadgada. Another variety of the similar Gadgada variety would be in a case of flaccid speech. It's about the minima. The flaccid speech where the muscles are not contracting properly, the patient would have characteristic hypernasality. Hypernasality is the nasal speech, the mean minor variety of the variety, and the patient would have to have take more breathing, like which you often see in case of motor neuron disease patients. Patients with motor neuron disease, the voice will be having a low intensity, and there could be a more of nasal intonation because the palatine muscles cannot contract fully, and that's how it could be seen. Then hyperkinetic is very often presented with them again neurological conditions like a stroke or so on, and where the patient, particularly stroke patients, as they recover as such, you will see that the patient would have a speech which is not able to be clearly understood, but and he may the patient may be able to produce certain variety of letters, but certain letters cannot be presented properly. This kind of the lesions often occur due to the central pathology, usually the basal ganglia, so most commonly seen in cerebrovascular patients during the recovery, and there could be tremors and dystonia. The tone of the muscles will be affected, and hence the quality of the sound would be affected. And this could be a variety of muka. I would consider this as a variety of the muka. Then another variety is hypokinetic. Hypokinetic is where there could be tremors and bradykinesia, very typical in case of the Parkinson-like conditions, where the sounds will be very slow. Patient would not be able to speak fast. It will be very slow sounds, which is also a variety of Gadgada. Now, in the Gadgada, now we may have two varieties, ataxic and hypokinetic. Or mixed reason, where the patient may have these all that variety where you are not able to make out whether it is hypokinetic or the other way. The patient is not able to produce the speech, and it could be a mixed variety. So maybe in the variety of Muka and Gaggara, somewhere that variety we may conclude that. Then the spastic varieties, which is more common, is usually due to the stress or patients who have maybe personality defects, like where the sounds will be very harsh, and the patients may have even this also can be seen in patients with the your psychiatric conditions and patients who are on antipsychotic drugs. Patients who are on antipsychotic drugs, they may develop certain extrapyramidal symptoms, and these extrapyramidal symptoms produced due to psychiatric drugs and extrapyramidal symptoms due to Parkinsonism. The difference is in the extrapyramidal lesions produced due to psychiatric drugs, antipsychotic drugs, would be having a spastic speech. Now, you might have seen many of the patients who are on such antipsychotic drugs, when they speak, they pronounce these words very loudly, and they are not able to pronounce the dirghaksharas, that all short duration. That's the typical of the spastic, which is also a variety of Gadgada. And then upper motor neuron lesions, where the patient is not able to produce the sound at all, and it's a total apraxia, where the patient is not able to produce any sound. All that sound would be monosyllable, like a, or so on, and that's again muka. So the whatever we consider as the dysarthria types, they can be categorized into the muka mean Gadgada. The difference is Sushoda has mentioned three categories. Now you may have seven. It's not only seven. There could be many more now. And the other way, aphasia. Now one is the classification of the aphasia, as I said about that way. Another way of classification of aphasia is the anomic aphasia or Wernicke's aphasia, and the Broca's aphasia, global aphasia. This is another way of classifying the aphasia. The another view of the aphasia is that aphasia also can occur if the patient is not able to hear the sounds, and if the patient is not accustomed to the sounds at all. And that kind of a situation can occur if there is a neurological pathology from the birth and there is an abnormality of the hearing. Because of the abnormality of the hearing, the patient is not able to produce the sound. That's also another variety cause for the aphasia. Now, in such conditions, we generally categorize the aphasia into the two types, fluent and non-fluent. In the fluent aphasia, where the patient has a inability to form the words, but he can form the voice. See, now I think I am clear. See, to produce a speech, there are two components. One is your voice, that intonation of the voice, the wavelengths of the air movement, and the waves of the air waves have to be formed. Another way is you need to have a formation of the word. The exact word has to be formed. Now, this exact word formation and abnormality of the speech is aphasia. Now, this is around a variety of the mukata. Muka can occur if a person is not able to form the voice at all or form the legible words. He may have the voice, he can, just like a child can cry, but child may not be able to produce a legible word in the beginning till it learns the words. A similar situation is due to again the global pathology where the central nervous system is affected. Depending upon the area of involved, you may have anomic aphasia, Wernicke's aphasia, and Broca's aphasia and global aphasia. So we have now aphasia and dysarthria as the two situations. All the types of aphasia are muka only. These are the varieties of the muka where the patient may be able to produce the voice, produce the voice as such, but he may not be able to have a word expression. Expression of the word may not be proper, and it can produce a fluent and non-fluent. And that's how it has to be understood. Like if a patient is able to understand the words, but he is not able to reproduce the words, that's anomic. And when the patient doesn't understand the word at all, is Wernicke's, which is usually seen in patients who have learning disabilities, and patient can comprehend the speech. Patient can understand the speech, and he can produce some speech which we can comprehend with the difficulty. It may not be as fluent as others. That's Broca's, and global is where the patient is not able to comprehend the speech at all. That's the global, as in patients with the severe dementia-like conditions. So that's about the aphasia. Now, and again, there are lots of words used in aphasia now, and these are not much important. The whole thing is, the whole details are too much now, and assessment of this and the speech therapy is a very elaborate issue, which is often more specialized. So we will not go into much of that. But if you look at the books, you will have lots of words related to the aphasia and it is particularly aphasia and dysarthria, and there is no need to be confused. It's all about describing the same symptoms in different levels, assessment of the different levels. And the most common words are eudaimonia, where the patient may have a difficulty in initiating the speech. These are all very commonly seen, and many times these are assessed as personality errors also. And particularly yeah. Then agrammatism, where the patient is not able to form the grammatical proper words, he may pronounce, his pronunciation may be different. Anomia is a difficulty in producing nouns. Patient may not be able to name the things. Circumlocution is associated words. These are all the formation, speech formation errors, personality errors, which can be either as a result of disease or which could be either as a abnormal or maybe variation in the learning capacity, and even it also could be occurring as a result of the diseases. These are all the words which are used to describe the speech formation in many of the patients in the present category. So no need, not very much important. The only issue is that Sushruta has not described these details. Instead, he has used the word Mukha Menina Gadgala. So no need of getting confused about it. You can understand the same in a detailed manner. Then the next is about the tuni and pratituni. A vatana vyadi. Adho ya vedana yati varcha umutrashayotthita भिन्नतीव गुदोपस्थं सा तूनी इति अभिधीयते गुदोपस्थ गुद उपस्थ उत्थिता सैव प्रतिलोम विसर्पिणी वेगैः पक्वाशयं याति प्रतितूनी इति सा स्मृता. Now a patient having a pain and in the abdomen and particularly in the lower abdomen, and the patient pain is produced in the mutrashaya somewhere in the supra-umbilical area or maybe around the umbilical area, and then it is radiating towards or getting referred towards the genital area, towards or radiating or pain radiating towards the lower surface. This is usually produced due to colic in the urinary tract. Ureteric, particularly ureteric. When the pain is produced with the pain is felt in the renal angle on the posterior side. When there is a pain which tends to move, very often the colicky pain. Now, colicky pain is often produced due to some movement in a lumen, like stones or a blood clot which moves in the ureter may produce the pain from loin to groin, which is the commonly used word. Pain produced originating in the lumbar area and towards the groin, and the patient may even having the pain towards the tip of the penis. That's the Guda Upastham. The Bindativa Guda Upastham. Patient may have pain towards the penis or genital area as a whole. That's a tuni. So tuni is a pain produced due to either the renal or ureteric pathologies. When it is in the renal pathology, the pain is felt in the back. And if there is if the renal pathology involves some colicky involvement of the smooth muscles of the urinary tract. I am not saying only calculi. See, one of the important is loin to groin pain often is equated to ureteric calculi. I don't say only the calculi. It could be any of those conditions which can produce a spasm of the smooth muscles of the urinary tract that can produce a typical pain which is radiating towards the penis, and that's what the tuni. Tuni is a virtue mutrashyochita bindativa gudopastham. It tends to be felt in the upastha, the genital area. Then a pain which is produced in the genital area, originating from genital area and tending to getting referred to the superior area, Gudopasthita Siva Pratiloma Visarpai, which tends to move upwards. Now, pain which moves upwards from which is produced from the penile area or maybe the genital area is mainly the prostatic pain. Now, prostatic pain, like prostatitis, the area of the pain which could be referred to from the prostate would be either it could be felt in the perineal area, or a pain from the prostatitis also could be referred to the legs, in the, maybe the middle aspect of the thigh. In the diagram, that middle aspect of the thigh is not specifically mentioned, but it could be the other way. Or it also can be often felt in the thoracic area, towards the superior abdomen and thoracic area. And quite important is that inflammatory pathologies of the prostate. The pain is often felt in the medial aspect of the thigh, perineal and medial aspect of the thigh. The obstructive pathologies of prostate, which is usually having no pain, but as a result of the obstruction, there could be a tendency for the hydronephrosis and urinary these infections. The pain is felt in the upper part as such. It could be somewhere in the thorax or the abdomen or maybe the back. So that kind of a clinical presentation is quite important. Of course, this diagram is about the malignancy of the prostate. A malignancy of the prostate can produce the secondaries, and any of these bones are involved, either into the skull bones or the facial bones or the bones of the lower limb also could be involved. So, a patient of prostate malignancy presenting the pain in these areas, they have to be considered as such. Now, anyway, we will not go into that detail, so we have much more information than what is relevant. But relevant would be in case of pratituni, it's a typically of prostatitis, inflammation of the prostate, is the typical presentation of a pratituni. Then साटोपम अतिग्ररुजम आर्भातमुदरम दृशम आर्भानम इति जानीयात घोरम वातनिरोधजम. The pain which is felt over the abdominal surface with some abnormal movements of the peristalsis. or distension of the abdomen. That's considered adhana. Now, adhana is produced due to vata nirodha, obstructive pathologies. Now, obstructive pathologies in the gastrointestinal tract can produce what we call as the intestinal colic. And colic of any abdominal structures, they could be considered as adhana. Adhana, atopa, and anaha. That differentiation has to be made out very clearly. Adhana is a painful condition where there is a colicky pain of the abdominal structures. Now, from the clinical point of view, it's quite important that if you have a very actual, correct history of the location of the pain felt by the patient, the diagnosis of origin of the colic can be made out. If the patient has a colicky condition of the stomach or upper part of the GAG, stomach, it could be either felt in the epigastric area or and as well as it could be referred to the back. Patient may have pain in the back, particularly in the mid thoracic segment, the midline. That could be an area. A patient produced due to the pain in the liver and gallbladder, it could be either at the right hypochondrium as well as it could be somewhere in the neck and shoulder on the same side, right side. There could be the felt pain. Spleen, of course, that the pain is felt exactly at the same area the spleen is, you may not have a distant reference. Appendicular pain is in the iliac area, and appendicular pain again, when the mucosa is affected, the pain is felt in the central abdomen, and then when the serosal surface is involved, then pain is referred to the specific area. Whereas if the lesions of the small intestine, they remain in the same, as in case of the obstruction, the pain is felt in the central abdomen around the umbilicus only. If it is a pathology produced due to the kidney and ureter, as we have discussed earlier, the pain would be loin and groin, maybe that's the area where it is felt. Cecal pain and ascending colon pain would be felt in the midline, in the hypogastric region, and sigmoid colon pain also would be felt in the same area. That's how the location of the pain now gives you more information. Of course, Sushruta has not mentioned this, so whenever you rewrite Sushruta, do a comment on Sushruta, you may add this, like by location of the pain being referred, you may go into more details, which Sushruta has not mentioned. Sushruta has considered all of them as a admana, colicky conditions of the abdomen. Whereas the conditions are vimukta parshvhridayam tadeva amashetam pratyadhanam vijaniyat kapha vyakulita anilam. Now, whenever there is an obstruction in the intestine, gastrointestinal tract, the first of the response of the body would be try to get over the obstruction by increasing the peristaltic waves. And during that state, the patient would have a colicky pain, and all that whatever you have discussed is about that state. But when the body is not able to get over the obstruction, and the colicky pain will subside, and it results in a adynamic state, adynamic obstruction. Now, aerodynamic obstructions, once the peristaltic waves become reduced, the nature of the pain changes. The usually what we see clinically is the intensity of the pain is reduced and pain gets localized to a certain area and the abdomen becomes more distended. There will be more distension and particularly the upper abdominal situation, aerodynamic pathologies of the upper abdomen, they will produce a pain in the chest and the size location as it, and the pain will be constant, dull aching type of pain constant, whereas a colicky pain there will be episodes of the pain. Now constant dull aching pain is typically the pratyadhana vimukta parshvhridayam, when the other areas like sides and other areas are lost, missed, and it's involving the abdomen and maybe the epigastric area, and there will be kapha vyakulita. Kapha vyakulita is usually a less intense pain and constant pain. It's the pratyadhana, aerodynamic stage as such. Now, the issue, which controversial issue is a gudodara, baddha gudodara also is mentioned. Udara, baddhodara also is mentioned. And these pratyadmana and atmana also are mentioned. In Udara also, we have a similar issue like a intestinal obstruction. Whether which of the conditions have to be considered as Udara, which of the conditions have to be considered as pratyadmana. That's the issue. Now, uh, what happens is From the current clinical approach point of view, we consider all obstructions as the same, but obstructions could be produced due to multiple causes. The very simple, make it simplified, obstructions could be produced due to primary pathology of walls of the intestines. The intestines may be constricted, or maybe there could be strictures, adhesions, and so on. Whereas obstruction also can occur due to extraintestinal manifestation, something which is producing a compression over the intestines, like a mass, a intra-abdominal mass, or the other. Or a obstructive symptoms also can occur due to neurological conditions. Peristalsis, if there is a absence of the peristaltic movements, that also can produce obstruction. Now, due to neurological conditions like toxic conditions, where you have consumed some toxic substance, poisonous substances, and hence the abdominal movements are reduced. Now, probably those conditions where there is a obstruction due to the primarily intestinal structures, they are considered as udara. Whereas the conditions which are produced due to extra-intestinal causes, they are considered as a admana or a pratyadmana according to Sushruta. That's how we have to understand. Then the next condition is the vata sthila. Now, vata sthila and mutra sthila. In the mutra kritra mutra ghata, Sushruta has mentioned about the mutra sthila, and the vata sthila is in the context of vata. But descriptions are the same. Whether they are the same or not, again, is a issue of controversy. From my point of view, I consider same. Or maybe patients who have the clinical presentation of an obstruction of the fecal route or in the rectal area, where you can feel a mass, asthilabad ghanam granthim urdhvam ayatam unnatam. When you put the finger into the rectum, rectal examination, you feel a mass. It could be then which also produces an obstruction to the outer passage. Bahir margavarujanam. When it becomes painful, that's called as a pratyasthila, and when it is relatively painless, that's considered as vatastila. Now, you have two possibilities. One is the fecolids, hardened stool masses, which also can produce the obstruction to the passage, and you can feel like a stone-like conditions as you put the finger in into the rectum, or the prostatic hypertrophy. Now, whether it's a fucoid or a prostatic hypertrophy in case of vata stela, it could be both ways. You may have a discussion, and as such, and probably what I would consider is a vata stela and mutra stela as the same. It could be a prostatic pathology, or the other possibility of vata stela being considered as a fucoid and mutra stela as a prostatic hypertrophy also is justified. Now, anyway, a prostatic hypertrophy, when you feel the prostatic swelling, the causes could be either benign prostatic hypertrophy or malignancy, the neoplastic conditions. Benign is where having a smooth course, malignancy you may have the other way, or inflammatory pathology, prostatic abscess. And one of the primary differences in case of benign lesions, the pain would be absent, lesser. It's only the obstruction which is the presentation. Whereas the prostatic abscess or prostatitis like conditions, pain is characteristic. It will be acutely tender as such. And a mass is felt when it becomes an abscess. In a prostatitis, we have discussed about in case of the pratytuni, where the pain itself is the same. When the prostatitis results in an abscess, you will be able to palpate it as a swelling outside the palpate. This is prostate. So when you palpate perfectly, that is made out prostatic benign prostatic hypertrophy is felt as a relatively firm swelling with the absence of the rugae. The rugae would be lost. Whereas a prostatic abscess will be somewhere in the any one of the lobes, so rugae will be present and it will be a tender, soft swelling which is present palpated over. Now, uh, when Sushruta says about the Bata Sthila, it's the relatively painless conditions where there is a hard granthi, whereas the same when it's present with the Ruja pain, that's considered as a Pratyasthila. So, these Pratyasthila and Asthila, they are very clearly the signs of either a neoplastic conditions of the prostate or a prostatic abscess. And then, of course, Ficolic as a Vata Stela also is a possibility. I do not rule out that, but maybe the other way is open for discussion. With this, we conclude the Nidana first chapter, vatavyadhinidana. Iti Sushrutamritayam Nidanasthane vatavyadhinidanam nama Prathamaodhyayah. Next, we will continue with the Arshas in the next session. If there are any questions, I will try to answer and then conclude today. Like there is one question. Um, Bachai is used for the speech disorder. In which condition does it? So is mainly for the central aphasia conditions, where the speech formation is difficult. It's a medhya. Medhya is acting upon the central nervous system, and hence it's for the speech formation as such. That's how it has to be understood, right? For the Muka variety. Hmm. Right. Now that question. So we'll conclude today.